Okay, welcome back. So what we'll do now is just have a quick run through General Medical Council guidelines. So we have to follow GMC guidance, but we also have to follow the teaching of the Church. So I think this is basically a good set of guidance for people like ourselves. Of course, the General Medical Council governs not just us, but all doctors, whatever their beliefs. And the burning question is, will they allow conscientious objection? I hope you've discovered that they do. But there are conditions attached, and there are one overarching document and one a subset of that. So there's good medical practice, which governs conduct and standards of care generally, and then personal beliefs and medical practice, which was first published in 2013, and it's very little changed since that time. In fact, it was some of what's in there was followed on from a rep from the GMC coming to one of our conferences and taking soundings of what we thought the problems were. So we'll run through quickly what the salient points of personal beliefs and medical practice. So these are actually screenshots from the guidance. So there's nothing paraphrased here. This is word for word. So number 3, they're telling us in so many words that they don't wish to prevent us practicing in accordance with our beliefs, but we do have to follow the guidance in good medical practice, and they don't want patients to be prevented from accessing the care that they want in other things that we probably wouldn't sign up to. So the important thing is to follow the guidance. And I have to say, whenever I've dealt with a junior doctor who was having difficulties, almost invariably they hadn't followed the guidance. So that doesn't necessarily mean that we'll stay entirely out of trouble, but a good starting point is to follow the guidance. We have to act in accordance with legislation, and we have to treat patients fairly, obviously. We mustn't deny them access, and very importantly, we mustn't cause patients distress. So that's a little bit of a red flag, because what constitutes distress? It's a very subjective thing. The distress itself is subjective, and what might cause it is subjective. And certainly I've had times in the past where I've said things to patients which I thought were entirely innocuous, and it still has attracted complaints. So the advice I would give really is to just think very carefully about what you say. Is this could this cause offence? Does it sound judgmental? Does it sound as though I'm being disdainful of the patient, that type of thing. And then the law doesn't require us to do things that we don't feel to be in the patient's best interest. Well, I think that's very helpful, because it means we don't necessarily get deep into theological or philosophical arguments. Purely as good doctors who want to act in the patient's best interests, we don't do things that we believe are harmful, and the law supports us in that. As far as objection itself is concerned, it's telling us we may opt out, but we mustn't discriminate against groups or individuals. So there are 2 important endnotes there. First of all, number 5 is telling us, it uses the example of transgender treatment, and it's telling us that we can choose not to be involved in that or to opt out of referring those particular cases. But what we mustn't do is refuse them general medical services, which really that chimes with our belief, because that would be very judgmental and punitive. If you think of the surgeon on the battlefield who treats enemy soldiers, it's not, it's human beings with rights and dignity that we're looking at. We're not judging them according to what their choices have been. And then they use the example of contraception. Again, we can opt out, but we mustn't discriminate between groups. So, for example, some people have the practice, I've heard of in the past, of giving contraception to married people, but not to unmarried. And that has been, I think a lot of Christians in other denominations have done that, and you can see where they're coming from, that they don't want to be complicit in fornication. But for us as Catholics, if we're practicing in an authentic way, for us it's contraception itself, which is intrinsically immoral. So we wouldn't involve ourselves in it at all. There wouldn't be exceptions to that, normally speaking. So, so that doesn't really prevent a problem for us. When we go for a job, our employers and colleagues and partners and so on want to know that we're going to be able to fulfill the contractual requirements. So, and the GMC is telling us this is a matter between us and our employers. So I think the most important thing is to scrutinise the job description very carefully at the beginning and look and see, I mean, is this job so full of things which are no-go areas for me? Could I do the job at all? Or are there a few areas that we can devise systems to get around? What I would strongly recommend against is, and I've come across it in the past, is people, you know, Catholic people who've gone for a particular job, knowing there were problems there, haven't brought it up at the interview, or haven't brought everything up at the interview, and then turned up to an operating list on a Monday morning with a litany of the things they won't do. And of course, you know, a consultant is outraged, and it gives a very bad impression of us. We weren't even courteous. We're trying to live the teachings of Jesus Christ, and we're not even being courteous. So to take on a job that we know we can't fall the requirements in would be foolish, really. And then we'll come back to number 10, but number 11 tells us, related to number 9, that we need to be open with employers and discuss these things with them in advance, which I think is very encouraging, it's very sensible advice. We don't need to keep our heads so far above the parapet. The General Medical Council is telling us to be open and discuss these things and find ways around them. And then we can explore whether we can put procedures in place which help us, enable us to do our jobs, but not to cooperate in evil in a significant way. Now, also, I mentioned colleagues here. We mustn't overburden colleagues. And of course, that's music to our ears, really, because, you know, if we're going to be authentic Christians, we can't go into a job and not do lots of the work or some of the work and expect other people to do for us, and then be overburdened and not getting any more money for it and so on. So a strategy that I had, and I've heard others use as well, was to offer to do more of their ordinary general medical work. And you know, work may be harder for us. So family planning, for example, is pretty straightforward. But if we're beavering away seeing elderly care patients with multiple pathologies and complications and so on, while they're doing simple family planning, sorry, that will probably make us popular. And it could be a good selling point. The other thing to think about is, particularly with general practice, that I'll be talking about later, but if we have something to offer to the practice, we don't just go along and give them a litany of the things we won't do. We do tell them those things, but also we may have extra things we can offer. So we may have developed a subspeciality, like dermatology or something like that, which enhances the practice quality, and also, importantly for GPs, brings money to the practice. And then number 10, they tell us that we need to let patients know in advance. Once again, a very sensible advice. And what I did during my time as a GP was to have a notice on the reception pointing out that I didn't provide family planning, for example, and that the patients were entitled to see a different doctor if they wanted to. And again, that's coming straight from the GMC. They want us to do this. And then some prescriptive things about how we should proceed if we have an objection. And first of all, we have to advise the patient, but be careful not to cause distress. Once again, you know, distress. How do you interpret distress exactly? And then we have to tell the patient they have a right to a second opinion. But I think there's a very important red flag here, because there's a difference between stating a right and facilitating that opinion, you know, in terms of the ethics of cooperation. So, as you know, I've come across people in the past who wouldn't do certain things, but just sent them directly down the corridor to another doctor. Well, that's a very proximate form of cooperation, which we'd have to avoid. And then it tells us that we have to make sure the patient has enough information to access another opinion. I never found that to be a problem, because if somebody came to me asking for something, say the pill, that I couldn't provide, and I went through the process of advising them that I had an objection and so on, courteously, and you're entitled to a second opinion, they might say, well, how do I get that second opinion? And even if the patient is very disabled, somehow they've managed to get to the surgery, to the desk, and round to my consulting room. There's no reason why that can't happen in reverse normally, either on their own or with somebody that's helping them. So being satisfied that they have enough information to access that opinion, I didn't really find a problem. And it's probably important also to document that in the notes. I was satisfied that the patient had sufficient information to obtain a second opinion. We mustn't obstruct patients, and really that's, in terms of Christianity, we don't have a mandate to police people's private morality. They are, if somebody's heading off to a supermarket with a machine gun to massacre innocent people, then hopefully we'd have the courage to jump on him or at least to call the police. But in terms of private morality, and even in the gospel, our Lord didn't chase after people that couldn't accept his teaching. He respected freedom. So we certainly don't want to obstruct. In fact, once I was in a debate with another GP from the Humanist Society, I think, and he came along with his hackles up, and he was thought he was going to be facing very severe competition or obstruction, and I pointed out that we're conscientious objectors, we're not conscientious obstructors, and if we do become that, then we will be in trouble. Obviously, we always have to be respectful of the dignity of the patient. And then this is going back to the overarching document, Good Medical Practice, telling us that we mustn't unfairly discriminate against patients or colleagues. Well, that's very good as well, because it works both ways. So certainly we shouldn't be discriminating against colleagues who don't share our beliefs, but neither should they. And so, if we do find ourselves in a situation where we feel we are being discriminated against, it may be worthwhile politely pointing this out to them. We don't want to be confrontational, but if we really are being badly treated, we should point out that the General Medical Council expects us not to be, expects us to treat each other with respect. So some take-home messages there are that we are allowed to have an objection in terms of GMC guidance. We need to check our job description very carefully, and then we need to be open with employers about developing ways of getting around the problems. We need to be honest and courteous. These are bog standard things, really, which we'd always hope to aspire to. The patient always has a right to a second opinion, and they have to have, and explaining to a patient how they can get another opinion is not immoral in itself. Perhaps we could deem that to be material, indirect, remote cooperation, but really, we're not sending them to somebody else to get a particular thing done. We're sending them to somebody else for a second opinion. There's no guarantee the doctor is going to give them the thing that we wouldn't. So what we're actually referring them for is a second opinion. And patients have to be aware of our objection in advance. Now, just to, I'm conscious there are some nurses here today, and the guidance isn't, I don't think, as comprehensive, but just to draw attention to the issue of conscientious objection. And today we have a very senior nurse here today, Teresa Lynch, who will be able to give us advice later. So with nurses, they are allowed to opt out, but they're not allowed to opt out of, for example, preparing the patient for a termination and that type of thing. But it does say here they have to speak to their colleagues in advance. And I would imagine that it's a question of actually setting up the right kind of atmosphere, the right relationship between you and your colleagues. So putting something in place where you're not actually asked to do these things. It's made very clear that you won't do these things. There's no point in coming to this nurse, and you should be really protected by the management from that type of situation happening.